Greetings and welcome to week 3 of Psychopathology and Family Systems. This is module 1 of 3. The second module is going to be slides only, but modules 1 and 2 will be videos. First, let's recap what we've learned so far. From weeks 1 and 2, we learned a little bit about the history of diagnosing, to learn about the harried past that was foundational for how we have historically thought about abnormal behavior. In the first 2 weeks, we were encouraged to appreciate the privilege of diagnosing with understanding that context, culture, and time are imperative to understanding people. Additionally, we've learned that prior to diagnosing, there is a certain therapist that is successful, and a successful therapist embodies the ability to connect well with different kinds of individuals. A successful therapist is adept at conversing. They extend patience, they're empathetic and warm, and they focus on providing humane treatment to everyone. Thus far, we have also gotten an understanding of the imbalance that comes from diagnosing. Diagnosing tends to create a hierarchy of power where there is a knower or an expert. And if there is an expert, then that means there is generally a non-expert. Often, the client is considered to be the non-expert. But in reality, the client is the expert. They are expert over their issues and their experiences, and the clinician is expert over how that constellation of symptoms come together to create distress and disorder. So in reality, both have a knowing, but of course around very different things. But what this does is it encourages that collaborative approach to diagnosing that we discussed. Importantly, we also learned that diagnosing is not the end all. Instead, diagnosing offers the roadmap for the treatment that is to come. Finally, we learned that over-pathologizing and minimizing are issues that can happen generally with any client, but particularly with BIPOC populations, this can be an issue. Current psychology, really still for the most part has white normative standards. And psychological theory tends to be based on those standards. So that means that what we understand may not reflect well the constellations of families that we see, the norms and the behaviors of all the ethnic groups. So to ensure better accuracy in our diagnosing, we understand that supplemental measures are going to be needed so that we don't fall prey to clinician bias. We recognize that minimizing and over-pathologizing is possible. Now that we have an appreciation for diagnosing, I want us to begin with the depressive disorders, because this is a common set of issues that most of us are going to see in our respective practices. Per the World Health Organization, an estimated 3.8% of the population experience depression. This includes 5% of adults, which breaks down to about 4% among men and 6% among women, and about 5.7% of adults who are older than 60 years old. This totals about 280 million people in the world that have depression. Depression, for another statistic, is going to occur about 50% more in women than among men. What are the depressive disorders? The depressive disorders include disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance or medication-induced depressive disorder, and then unspecified depressive disorder. You'll notice here that major depressive disorder also is referenced as MDD. On another slide or an upcoming slide, I will reference disruptive mood disorder as DMDD. What I want you to be aware of is that there are other disorders in this category, persistent depressive disorder, premenstrual dysphoric disorder, that are both PDD. I mention this to say, over the years, students have given, they've given abbreviations to diagnoses. If I don't offer, or the DSM doesn't already offer, an abbreviation, please spell out the disorder that you are referencing. Otherwise, there might be confusion in what you mean. But these are the disorders, and then we have unspecified depressive disorder. All of the disorders in this grouping are going to share some common features. They're going to share sadness, emptiness, and/or irritability in mood. As it regards the physical changes, we should notice physical changes along with that. Cognitive changes should also be evident, like shifts in thinking pattern, slower thinking, concentration, so much so that the ability to carry out the usual activities are impaired. So regardless of the disorder, those are going to be central features: the mood piece, the physical, and the cognitive changes. So I'm going to briefly go through the four major disorders in this category, and then I'll expand on them. Briefly, disruptive mood dysregulation disorder entails persistent irritability that is extreme and that lasts for at least a year. Okay, that's going to be your disruptive mood disorder, something that's going to be chronic for at least 12 months. Your major depressive disorder, which is the classic disorder in this grouping, entails the sadness and or grief, right, that reaches clinical levels, and that sadness is different from normal or expected sadness or grief. For instance, somebody passes away, an individual will experience sadness or grief as a result of that loss. That in and of itself, when it is expected, would not be considered to meet clinical levels. However, when it falls outside, has been going on for a period of time that's outside of an expected or usual period of time, then we might start to think about whether or not a disorder has set up. The depressive disorders also include persistent depressive disorder, which is chronic in nature and not episodic. So I'll expand on this when we move forward in talking about major depressive disorder, but it appears in chunks, 2 weeks to 3 months, or 4 weeks or something like that. Those are considered episodes. A persistent depressive disorder is not episodic. Instead, it is a chronic form of depression that's less severe than major depression, but is generally present in an ongoing nature. So it's more like a dysphoria compared to a depression, and it's ongoing, sort of a ongoing melancholy. Finally, in this grouping, there is premenstrual dysphoric disorder, and it entails instability in mood related to a woman's menstrual cycle. Let's look a little bit more deeply at disruptive mood disorder, or what's referenced as DMDD. Disruptive mood dysregulation disorder has its greatest impact on individuals between the ages of 7 and 18. Notice that in my bullet points here, the onset occurs before 10 years old, but not before 6 years old. So, what would be significant about onset not occurring before the age of 6? Just think about that for a moment. What sort of things do we expect to happen at 6, but maybe not before that? Let me help you out. At the age of 6, most children are in school, they're under structured environments. Certain things are expected of a school-age child. It's expected that they are developmentally capable of settling down once given direction or being told to do something, and to some degree, right? We also expect that at that age, language is also fully established, as opposed to the language of a toddler, for instance. For most, potty training, at least during the day, is complete, and tantruming is a thing that's usually in the rearview mirror of a 6-year-old. I mean, there may be some, but not as much as this disorder presents. Also, and kind of finally, in thinking about this age and developmental stage, there should be a bit more understanding about social norms and being able to accept direction, knowing that direction comes and that it is expected to be followed. However, if at a 7 to an 18-year-old, if extreme resistance is present to the point of tantruming, then we need to be considering whether or not there is some level of disordered behavior at play, okay? And perhaps this disorder in particular. As an adolescent moves toward adulthood, we might expect that the tantrums transition into depression or anxiety, right? Because the likelihood that we're going to see an adolescent tantruming is going to be less so. But we'll talk in a bit about what those tantrums look like. This disorder is commonly seen in mental health clinics with parents presenting with their children as being out of control and unmanageable. Those are the sort of words that sort of clue us in to perhaps the potential of disruptive mood. DMDD is perhaps the most appropriate disorder to give over and against giving a bipolar disorder, which is also a mood disorder, right? But for this population, DMDD may be the more appropriate disorder, at least prior to adolescence. At adolescence, a bipolar disorder or condition might better explain the constellation of symptoms, but you want to look at the entire constellation of symptoms before determining, have I moved from a disruptive mood dysregulation disorder to a bipolar condition? Again, it's not expected that an adolescent would tantrum, but this disorder allows for that, but the tantrums may shift and be replaced with mood symptoms. Now, disruptive mood dysregulation disorder has the primary feature of the chronic, persistent, and severe irritability. It's important to note that when we're talking about the tantrums, they can be presented either behaviorally in the way that maybe we're thinking about or used to seeing tantrums and the flailing about. They can present that way, but they could also present in this verbal tantrum, in this verbal rant that usually comes on, the tantrum usually comes on as a result of poor frustration tolerance. The thing that makes this a disorder also, apart from the extreme nature, is that the behavior that is extreme is really unmerited. It's not understood or explained by the circumstance. So, for instance, a simple command could result in this tantruming and breakdown. For example, a parent could say, I need you to turn off your phone so that you can begin your homework, and a tantrum results. So, the extreme nature of the response doesn't fit the circumstance. So we're looking for that when we're getting our information and we have parents saying, oh, this was the outburst, this was the thing that happened. We want to know what preceded that, what might have been going on, just to see if perhaps there's any context for the behavior. To meet diagnostic criteria, the extreme irritability has to be present 3 or more times a week, and because it's chronic in nature, it needs to be in place. It needs to be the presentation for this person for at least 2 or more years, and present across multiple settings, right? So this isn't just a developmental phase that the child might be going through, right? When we see that it is ongoing for 2 or more years, we move from age 7 to age 10, right? Now we are at the place where we could say, I've seen this at age 6. I can diagnose it at age 7 because it's been going on now for 2 years. Like we're almost through age 7, right? And not only is this child doing or engaging these behaviors with a single person in a single setting, it's happening across multiple settings. A single setting might suggest that something is amiss in that particular environment or even with those individuals. So we would want to look into that. Even when we hear the parent give us that information, we're asking, where else does this occur? With whom else does this occur? Because if the behaviors don't show across multiple settings and people, then there's consideration that maybe there's something specific again. But if it's across settings, across people, it doesn't really matter who the person is. These same extreme behaviors present, and it's been chronic and ongoing for 2 or more years. We're considering that this might be a disruptive disorder. Now, in between the tantrums, the anger and the irritability are present. So you may have the tantrum, and then when that is subsided, there's still that crankiness, that irritability that's present. Now, we talked before about differential diagnoses and comorbid diagnoses. I'm going to talk here about differential. Differential diagnoses, again, are those issues that may seem to mimic another disorder because they have some shared symptoms. A comorbid condition is one that does not necessarily share symptoms, but co-occurs. It's occurring at the same time. Disruptive mood dysregulation disorder could be, for example, comorbid with a substance use disorder. Okay, so the difference between a differential diagnosis and a comorbid diagnosis. With this distinction, between comorbid and differential, oppositional defiant disorder and attention deficit hyperactivity disorder may be differential diagnoses for a disruptive mood disorder, but you want to make sure that there is understanding that for disruptive mood dysregulation disorder, the primary feature is the mood, right? And dysregulated mood, different from what we'll find in oppositional defiant, but both seem to present to some degree as a frustration tolerance. But I wanted to note that both of those could be differential diagnoses. So just because you hear this tantrum doesn't mean, voila, I've got it. You need to dig deeper and make sure that you're not seeing defiance or that you're seeing symptoms of an attentional issue. From a relational context, it should be understandable that a diagnosis like disruptive mood dysregulation could cause interruptions in families, in a marriage, and with peers, right? So if you have a child that has disruptive disorder, that is going to create all kinds of conflicts with the siblings, perhaps between the parents, and certainly with other same age peers where this individual is constantly verbally lashing out or even behaviorally lashing out. This disorder has further implications for a child's ability to perform well in school, particularly if there is impaired distress tolerance, right? The teacher says to do one thing and the distress tolerance causes the outburst or leads to the outburst. This dysregulation might certainly place a person at risk for suicidal ideation or even aggression that is severe. So when your relationships are disrupted, even though it may be a function of something you're doing, it doesn't mean that it doesn't create other impacts and lead to some suicidal thinking or even some aggressing in response. As I note here on the slide, a disruptive mood dysregulation disorder is correlated with the things that happen in a child's life. Childhood trauma, parents who are wrapped up in substance use issues, children of divorced households, death, or even a child that frequently relocates. So let me pause, or let me just emphasize and encourage that you think about the diagnoses as making sense to the circumstances. You should consider what a person's experience could create in terms of disordered and distressed behaviors. So, in thinking fully about DMDD, it should make sense that an unstable childhood environment of trauma or frequent relocation could produce a dysregulated mood and response, right? That might be enacted or acted out as extreme tantrum. Okay, so this should start to make sense when we're thinking about what was going on, because the cause gives us indication of what to do. If family disruption is part of the issue, that may have to be where our work is focused and not just on the child as the problem. So let's move on to the major depressive disorders major depressive disorder as the common issue in the depressive disorders. Sorry about that. To meet criteria for a depressive disorder, symptoms need to be present nearly daily and for most of the day. Okay? We go back to the mood because this is a mood disorder. A sadness, whether it's stated, I feel sad, or whether it's demonstrated through the person's demeanor or presentation, that sadness should be present along with disturbance in things like sleeping and eating, either too much or too little. The person sleeps too much, they eat too much in response to the sadness or along with the sadness, or too little in both instances. There will also be those physical changes that we should see, like the psychomotor slowing in their speech or movements or even thinking, or even some psychomotor agitation, the pacing, the hand wringing, all indication of those physical changes in the individual. Depression is one of those conditions that can strike both children and adults. Whereas adults may present with a hallmark symptom of sadness and crying, right, or even the grief, children may present with more irritability and crankiness. So, with the sadness or the irritability, there will also be a loss in the interest or pleasure in activities that are usually enjoyable, right? So they're sad, and that also means I don't really want to do the things that usually bring me pleasure. Like I mentioned before, this diagnosis indicates that the sadness or the irritability occurs in spurts or episodes. The episodes have to be at least 2 weeks in length. They can be longer, up to 3 months, let's say, but they have to be at least 2 weeks. Now, this 2 weeks is very different from colloquial understanding of depression, where a person may be sad for a day and they say, oh my gosh, I'm so depressed, right? I know that's language that we use, but we have to steer away from accepting colloquial language as meeting criteria and actually asking about, well, how long has it been present? And has it been present nearly every day, most of the day, okay, for that 2-week period of time? Often, like I mentioned, the symptoms last longer than 2 weeks. Sometimes they can last up to 3 months. But in that sadness, the physical and cognitive changes should be pretty evident, because depression is a slowing, right? Depressing, slowing. It is a slowing down and a retardation. And so that should present across the board. It should present in the person's demeanor, in their speech, in their movement, right? Everything starts to slow. Their ability to process should also be slow because of the depressive state. In addition to the sadness or irritability, the person has to have at least 4 more things. So it's not enough just to be sad. There also has to be a feeling of worthlessness or guilt, some difficulty in cognitive processing, concentrating issues, recurrent thoughts of death. There should be suicide or suicidal ideation or plans, right? An additional 4 more symptoms, not just the sadness. Because, again, if it is a disorder, it is creating disruption. And if it's creating disruption, there's probably a constellation of things going on. The constellation of the symptoms and the disruption should create impairment if it's at a clinical level. With any disorder, you want to become familiar with who tends to be stricken with the condition. So, you know how I started this series of slides by giving us just some statistics, right? More women than men. We need to become familiar with who is usually plagued by the various disorders, so that when we hear the symptoms start to present in a person who fits that category, we at least go through the symptomatology to rule in or rule out the presence of the disorder. Depression usually impacts young adults, though it can impact any age, with adults with adult females being diagnosed more than adult males, right? So, like I said, depression can happen in children, but it tends to be more of a young adult issue. It's not relegated only to adults, though. Now, when we think about more women than men, here's where we say, is this because more women are actually experiencing more depression, or is it because more women tend to participate in therapy? Are more women open to sharing that they have depressed feelings? Is depression acceptable for men to say they're suffering with, right? So we do hear the numbers. We know who we might be looking to see this in, but we don't negate that it is also present in men. And so even if, again, like I said, somebody might say that they're sad, but let's say they don't say it, but their demeanor shows that, right? Which might be more the case in men. We still go through this process of trying to determine, is this male in front of me experiencing depression? As mentioned already, the symptoms need to be present for at least 2 weeks. They can last longer, 3 months or more for lots of people. And when diagnosing, we're going to start to identify the diagnosing with more specificity. So we're going to say with depression, is this a single occurrence? Meaning a single occurrence. This means this is the first and only occurrence of the episode, right? This is the first time. Or does this episode mark a recurrence? So if somebody's come to you and this is the first time that they've seen somebody, right? And they say, no, I've had this for a while. This is the first time that there is a clinical diagnosis. So you might go with a single case. If they had seen another provider, they're coming back to you, and this is a subsequent episode, then you would say that it's recurrent. As you'll see in the DSM, many of the categories of disorders have specifiers. Okay, so for major depression, the specifiers speak to the severity of the episode and the constellation of symptoms. So here you would indicate that the depression is mild, it's moderate, or it's severe. When we're talking mild, moderate, or severe, we're usually talking, and I think the DSM will expound on this, the number of symptoms. So if you have if you have 5, right? Because you have to have the sadness plus the 4 additional. But if you start to have more on top of that than just those absolute minimums, then we might say it's moderate, as well as the disruption it causes, right? So you could have 6 symptoms, but the disruption is minimal. You could have 5 symptoms, but the disruption is pretty significant. It could be moderate, right? But if it's severe, we're going to see a lot of what we talked about in terms of the psychomotor slowing and the thought processes and those sort of things. But if you have a severe course, you have to indicate whether or not psychosis is present. So you would say with or without psychosis, okay? And you will want to specify if the episode is in partial remission, full remission, or unspecified. Okay? Partial remission, the person is saying they're starting to get better. If you're just seeing them, you're gauging that it's in partial remission given how they've indicated they felt at one time and how they feel now, versus full remission where the client is telling you about something that is more in their rear view mirror. If it's really unclear to you if they're fully out of it, you'll just say unspecified. Remission, just for clarification, is thought to represent the absence of clinically relevant symptoms, meaning the episode has ended, and if they were in treatment for that, treatment could be discontinued or shifted to preventing future episodes. Okay? So when we're saying remission, that means, okay, we've wrapped up what we needed to do here. We're all good. We could focus on how to maybe prevent other episodes, but we can say we have successfully managed this episode if we say full remission. We might expect that someone in full remission is not coming to us for therapy, or at least not for treatment for depression. Okay, instead, they may be reporting a former episode that you include in your history gathering at intake. So if you have in your diagnosis major depressive disorder, full remission, that means this person has probably more recently had the diagnosis versus saying something like by history, which means it's a part of their history. The full remission suggests this is something that perhaps they more recently resolved. Again, thinking broadly about diagnosing. If someone has had a depressive episode, then you're on the lookout for other diagnoses, particularly other depressive episodes, particularly if there have already been more than 2 episodes of depression. So what does this mean? When a client with a history of depression is going through an unrelated matter, let's say, you will want to be mindful of their susceptibility of a recurrence. So maybe they had a full remission, but they've been depressed a couple of times. Now they're dealing with a work event or a relational event. We want to, while we are managing the relational or the work issue, to be assessing in the background for depression and the onset of those symptoms, guilt, worthlessness, suicidality, those sort of things. Now, I've listed other specifiers here on the slide. Certainly, if you can take a moment to look at those, certainly if someone is melancholic, this is going to indicate a more severe and impactful course. And melancholic meaning somatic features, the weight loss, the loss of sex drive, guilt, those sort of things. It's going to be a more severe course than somebody who doesn't have that sort of somatic representation of the sadness. Psychotic themes are also elaborated on here, whether they are mood congruent, mood incongruent, those sort of things. You can note whether or not the episode was seasonally manifested, was a function of postpartum, those sort of things. When we think about depression, again, it's very common of the disorders in this grouping. When we hear that a woman has or is dealing with some sort of a postpartum depression, our ears want to perk up. And our ears want to perk up because that sense of being incapable and worthless and guilty could be a part of that depressive episode. And when a woman is responsible for taking care of a child that she doesn't feel like she's able to do, that puts both the child and the mom at risk. And we've seen this in the news and so forth, sadly. So when we hear that there is depression that is postpartum, we want to absolutely pause on that and make sure that we've done safety checks for the child as well as the mom, and we want to make sure that there are social supports available. Okay? Now, as I mentioned early on, maybe in the introduction. Um, I am encouraging you to view the film short in Call Me Crazy on Eddie. He's one of the characters. I believe that his story comes in maybe at, like I said, 56 minutes. Some of these episodes are broken up. So somewhere in the story, it may start with one part of their story and then go to another part of their story. So I believe his story goes through. It may break and come back after talking about another character in the movie, but I would really encourage you to watch Eddie's story and this episode so that you can use it as sort of a training module to see what it looks like, and also to maybe pair with somebody to engage a clinical dialogue. So in this slide, I have offered a clinical vignette to Eddie and his wife, Julia, her name is Julia, to round out their story. So if you're able to watch the movie, I just added my own stuff here with backstory and that kind of thing to create context. But to offer yourself some practice in talking through an intake session aimed at ferreting out depression, consider partnering with one of you acting as Eddie or even Julia, and the other person acting as the therapist and switching off so that you get experience with the assessment and just sort of delving into the backstory, getting an understanding of the symptoms. You can use the clinical vignette to do that, even if you don't watch the movie, but the movie, in my opinion, again, does a great job of exemplifying the mental health issues that it portrays, that I think it's worth getting the video. This is more of the vignette, but should you pair up, consider answering these prompts. Even if you don't pair up with a classmate, get some practice just thinking about the prompts. And in subsequent modules, we'll continue to delve into the other mood disorders, as well as bipolar and related disorders. And I will have, for some of those, some related vignettes. But you see here I've put in questions like, what are your working diagnoses? What are your differential diagnoses? At this point, we only have the mood disorders that we've discussed, but as we build on the disorders that we learn about, that's going to become part of what I'm asking. What is the differential diagnosis, right? Or what are the comorbid diagnoses with this particular diagnosis, right? So when you're asking yourself this week to week and you're really sort of fleshing this out, take your time. I want at the end of each week for you to feel like you have a full grasp of the disorders in this particular category. Okay, so that's going to do it for the depressive disorders. And we're going to move on, like I said, into bipolar and related disorders, which are also mood disorders.